Hey, I'm a psychiatrist, and a few weeks ago, a patient in clinic asked me, "Hey Dr. J, I keep seeing articles about psilocybin for depression. Should I try it?" Now, this was an interesting question to the least, and without going into too much detail here, we had a deep and clarifying conversation regarding their thoughts on psilocybin. And in that moment, I also realized that there's this massive gap between what a lot of people understand about this compound and what's happening in cutting-edge research all over the world. You see, psilocybin, which is the active ingredient in what people call magic mushrooms, is suddenly everywhere in mental health news. There are clinical trials, FDA breakthrough therapy designations, and major universities are studying it more and more. But here's the thing, most of what's being shown in headlines doesn't match the clinical reality of how this compound actually works or how it's being researched. So today I'm breaking down what psilocybin actually does in the brain, what the research shows, and what you need to know about this as a potential mental health treatment. If you're new here, I'm Dr. J, and I'm a medical doctor specializing in psychiatry, and my sole goal is to make mental health make sense to you. Now, before we go any further, I need to be crystal clear about something. Psilocybin is a Schedule I controlled substance in the United States, which means it's federally illegal. This video is about science and clinical research. It is not a recommendation to use this compound, and definitely not outside of a legal research or clinical setting. Our discussion today is educational, and if you have questions about your individual health, please talk with a licensed medical provider. Okay, for our first points, let's talk about what psilocybin is and how it works in the brain. So, psilocybin is a naturally occurring compound found in over 200 species of mushrooms, and when you ingest it, your body converts it to psilocin, which is the active form that affects your brain. And psilocin works primarily by binding to serotonin receptors, specifically the 5-HT2A receptor. Now you might ask, why does that matter? Well, it's because serotonin receptors are involved in mood regulation, perception, and cognition. So when psilocin activates its receptors, particularly in high doses, it creates what researchers call altered states of consciousness. That includes changes in perception, thought patterns, emotions, and sense of self. I want you to think about someone in a clinical trial receiving psilocybin. They're not just getting high in the recreational sense. What's happening in their brain is the brain's default mode network, which is basically the network that maintains your sense of self and your habitual thought patterns, temporarily becomes less rigidly connected. And brain imaging studies also show increased communication between brain regions that don't normally talk to each other. For example, researchers at Johns Hopkins and Imperial College London have used functional MRI scans during psilocybin sessions, and they found that areas of the brain that usually operate separately start showing synchronized activity. Some researchers describe this as the brain becoming more flexible or plastic temporarily. You see, this is super important because in conditions like depression or PTSD, people often get stuck in rigid negative thought patterns, and the brain unfortunately keeps replaying the same loops with thoughts such as, I'm worthless, or nothing will get better, that trauma defines me. And psilocybin seems to temporarily disrupt these rigid patterns, which might create a window where new perspectives become possible. But, and this is huge, that disruption alone isn't therapeutic. The research shows that the therapeutic benefit comes from what happens during that window, including things like the psychological support, the integration work afterwards, and the meaning people make of the experience. Okay, for our second point, let's talk about the actual research happening right now. In 2018, the FDA granted psilocybin breakthrough therapy designation. And this was for treatment-resistant depression, which means the FDA recognized that preliminary evidence suggested this could be a substantial improvement over existing treatment. And that designation basically fast-tracks the research process. Now, what does the research actually show? Well, one of the most cited studies is from Johns Hopkins, published in 2016, and it looked at psilocybin-assisted therapy for people with life-threatening cancer diagnosis who were experiencing anxiety and depression. The results was about 80% of participants showed significant decreases in depression and anxiety. And these improvements lasted quite a while. For many participants, benefits were still present 6 months later. Another major trial from the Imperial College London, published in 2021, compared psilocybin therapy to escitalopram, which is a standard SSRI antidepressant. And these are both for major depression. Both groups improved, but the psilocybin group showed a faster onset of effect and, in some measures, greater improvements in well-being and emotional connection. There's also research on psilocybin for obsessive-compulsive disorder, addiction, including alcohol use and tobacco use disorder, and end-of-life anxiety. But here's something that folks don't realize when they read these headlines. These studies aren't just giving people psilocybin and sending them home. The protocol typically includes multiple preparation sessions with trained therapists, a supervised dosing session that may last from 6 to 8 hours with continuous psychological support, and then several integration therapy sessions afterwards to process the experience. For example, in the Johns Hopkins protocol, participants met with therapists multiple times before the psilocybin session to build trust and set intentions. During the dosing sessions, they are also in comfortable rooms wearing eye shades, listening to curated music with, 2 trained facilitators present the entire time. And afterwards, they have therapy sessions to integrate what came up during the experience into their daily life. The idea here is psilocybin is not a magic bullet. It's more of a catalyst that works within a structured therapeutic context. For our third point, let's break down the specific conditions being studied and why psilocybin might help. One of them is treatment-resistant depression. And this is one of the most researched applications and is defined as folks who have depression and have tried multiple antidepressant medication without success. You see, psilocybin-assisted therapy might be showing real promise. The theory is that by disrupting rigid negative thought patterns and creating neuroplasticity, it can help people break out of depressive loops that haven't responded to other treatments. Anxiety in terminal illness is another major area. When someone is facing death, they often experience what's called existential distress, which can include fear of dying, loss of meaning, and disconnection from loved ones. Psilocybin sessions, when properly supported, seem to help people process these fears, and they often report experiences of acceptance, connection, or even transcendence that overall reduces their anxiety. Now, on the other hand, addiction is a fascinating research topic because the mechanism might be totally different. Some researchers think psilocybin helps by creating what they call peak experiences that shift someone's sense of identity. Like someone who's been smoking for 30 years and defines themselves as a smoker has an experience where they see themselves differently, and that shift in self-perception may support behavioral change. There's also emerging research on cluster headaches or anorexia nervosa and even cognitive flexibility in healthy individuals. But, and I really want to emphasize this, all of this research is preliminary. We're talking about small studies and we don't have FDA approval yet for any psychiatric indication. So overall, the research appears promising, but we're not at the point where this is standard clinical practice. Which brings us to our fourth point. Let's talk about safety. Because whenever something works, we also need to know what the risks are. And in controlled clinical settings, psilocybin has a relatively favorable safety profile. It does not appear to be addictive, and there's been no significant evidence of physical dependence or withdrawal syndromes. It's usually not toxic to your organs like alcohol or stimulants can be. And the lethal dose is extremely high, so generally pretty difficult to reach accidentally. But this does not mean psilocybin use is without risks. The biggest risk is psychological distress during the experience. People can have what's called a challenging trip or a bad trip, and these come with intense anxiety, paranoia, confusion, or frightening perceptual experiences. And in clinical trials, this is managed by trained facilitators who can provide support and reassurance. But outside of that setting, it can be genuinely distressing and potentially traumatic. There's also a risk for triggering or exacerbating psychotic symptoms in people who are vulnerable. You see, if someone has a personal or strong family history of schizophrenia or bipolar disorder, psilocybin could potentially trigger an episode, and this is why clinical trials have strict exclusion criteria. Another concern is what's called hallucinogen persistent perception disorder, or HPPD, where visual disturbances continue after the drug wears off. Now, this is rare, but it does happen. And then there's the context risk. And this is where someone takes psilocybin in an unsafe environment, let's say at a party without support and combined with other substances. In these kinds of situations, the risk of harm increases significantly. Settings generally matter enormously with psychedelics. Also, remember, this is a Schedule I substance, so possession, use, or distribution outside of approved research settings is a federal crime. Some cities and states have decriminalized it, but that doesn't make it legal federally. Which leads to our fifth point. Let's talk about the reality of access right now. As of 2024, psilocybin is still federally illegal in the United States. However, Oregon has legalized supervised psilocybin therapy through licensed facilitators. Colorado voters also approved a similar model, and several cities including Denver, Oakland, and Washington, D.C. have decriminalized possession. But here's what that means for access. In Oregon, for example, you can't just go get psilocybin from a doctor. You have to go through a licensed service center with trained facilitators. It's pretty expensive, actually, often several $1,000s in fees, and insurance doesn't cover it at this time. For most people, the only legal access is through clinical trials, and those have specific inclusion criteria, usually for conditions like treatment-resistant depression or terminal illness with anxiety like we talked about earlier. You generally can't just sign up because you're curious, unfortunately. There's also a growing underground scene of facilitators and retreat centers, and some of these organizations operate in decriminalized areas, and some operate illegally, and some operate in countries where it's legal, like Jamaica or the Netherlands. As you probably guessed, the quality and safety of these facilities vary enormously. Some are run by trained therapists with clinical backgrounds, and some others are not. And there is no real regulatory oversight. The most important point of this video is that psilocybin research represents a potential shift in how we think about mental health treatment. You see, for decades, psychiatric medications have somewhat focused on symptom suppression to an extent. You take an SSRI every day to keep your serotonin levels up, or you take a benzodiazepine when anxiety spikes. The model has been medication manages symptoms, hopefully indefinitely. But psilocybin assisted therapy, if the research holds up, offers a different model. The idea is a limited number of sessions, maybe even 1 to 3, can create lasting change by addressing underlying psychological patterns rather than just suppressing symptoms. That's really exciting, but it's also complicated because this requires a massive infrastructure we do not currently have. I'm talking trained therapists, supervised settings, integration support. It requires things like insurance coverage and regulatory frameworks, addressing the stigma of misinformation, and just ongoing research to understand who it helps, who it doesn't help, and how to optimize the protocols. Overall, psilocybin shows real promise for certain mental health conditions, particularly when conventional treatments haven't worked, but we are very much in the research phase. Now, if this at all made sense to you, I think you want to watch this video right here that breaks down how ketamine therapy actually works for depression. It's another psychedelic compound that's actually already FDA approved for treatment-resistant depression, and it's available in many clinical settings. I want you to definitely subscribe for more videos like this in the future, and comment one surprising thing you learned from this video in the comments. I read and respond to every single comment, so I'm looking forward to hearing your thoughts. In the meantime, I'm Dr. J, and this has been Mental Health MD. I'll see you in the next video. Bye.